It is June the 28th, 2019, and this is episode 11 of the official podcast of the Royal New Zealand College of Urgent Care. Coming up on today's slightly shorter episode, we hear Dave Sorrell's thoughts on fundoscopy, we look back at our bite on local anaesthetic eye drops, we hear about an interesting genetic study on drug reactions, and we look at a study in the news linking dementia with anticholinergic use. Hello and welcome to this abbreviated episode 11 of the official podcast of the Royal New Zealand College of Urgent Care. My name is Guy Melrose and we are without David Sorrell today as he has left the country on a much deserved holiday, but we were able to get his thoughts on a couple of urgent bites before he left. Sadly, owing to technical difficulties, what was meant to be a conversation ended up just being him giving some thoughts, so that's better than nothing, I'm afraid. So first up, we take a look at the bite on fundoscopy. Are our skills at fundoscopy so poor that we should actually forego it altogether in favour of things like retinal photography or point-of-care ultrasound scans? Well, here are Dave's thoughts on this one.
So when we consider examining the fundus, I guess you have to work out how important the test is. We know that the diabetic clinic does not rely on direct ophthalmoscopy anymore, and so they will examine the retina with the slit lamp in indirect fundoscopy, or they will do retinal photography. So I guess you'd have to consider how important the test you're doing is, because if you're like myself and you find fundoscopy very, very difficult, and you imagine that you've probably got the average accuracy, which may be 18%, then if I need fundoscopy done, I would refer someone either to an optometrist for retinal examination, usually photography, or to an ophthalmologist if it's urgent. So when we're looking at the retina, usually I am looking for, because of the patients that I see, I'm looking for commotio retinae, or a bruise on the retina from eye trauma, or retinal detachment, or vitreous detachment. I am sending them to an ophthalmologist for dilation and examination of the retina. I think that papilloedema is probably one of the hardest things to see in medicine if you're not good, and I am not good at examining the retina. So I will send someone for an accurate test somewhere else, in the same way that I wouldn't try measuring compartment pressures in my urgent care clinic, because I know all the ins and outs of rigging a MacGyver-like pressure meter for compartments, but I would send somewhere where it could be accurately measured. Also, I don't have a tonometer as well, and I wouldn't consider pushing on eyeballs to determine that there is raised intraocular pressure.
So for me personally, I think I have confidence that I can see the disc with a panoptic ophthalmoscope most times, but is that enough to exclude papilloedema? And are my skills when I see the disc good enough to be certain that this patient hasn't got papilloedema? Certainly in the presence of other concerning features in the history or exam, I wouldn't consider using it alone as a rule-out test. But I still find myself doing it, and if, like me, you find yourself still doing the test, it's obviously vital that we document that we did it. An article in the May edition of the New Zealand Medical Protection Society casebook talks about a case of papilloedema relating to an acoustic neuroma. And part of the complaint that was brought against the GP in this case was that fundoscopy was not recorded by the GP, or at least the GP remembers doing it, but it wasn't documented, and so there was contention over that particular point. Given that the subsequent fundoscopy by the neurologist was normal, it was deemed that it was probably a normal test when the GP did it. However, the GP hadn't documented it, so like many things in medicine, if you haven't documented it, then have you done it? That case highlights the importance of documenting doing a test, like fundoscopy, even if the test were normal. But I guess what Dave is saying there is doing the test enough to exclude the thing that you're concerned about? And it is interesting that in this case, in the MPS article, that papilloedema was actually picked up by an optometrist, having the patient been to their GP and the neurologist having had direct fundoscopy, and neither of them saw papilloedema. But we don't know whether papilloedema wasn't there, therefore they couldn't see it, or whether they looked but missed it. But it was certainly an optometrist in this case that found it. So maybe optometrist retinal photography is the best way to exclude papilloedema in our patients who maybe don't require an emergency referral up to the hospital. So it's tricky. One thing we must all do in urgent care, obviously, is to make sure we've asked about red flags and look for red flag signs for anyone with a headache, and to make sure we document those things very carefully. And it's also very good practice to safety net your consultations and make sure that there's some form of follow-up in place, at least with the patient's GP, or as Dave was indicating, referring for some retinal photography might be an advisable thing for us to be doing. So let us know your thoughts via podcast@rnzcuc.org.nz. Let us know what you personally do. Let us know whether you do get retinal photography done, or if you happen to use point-of-care ultrasound, which is the other thing that's being used now to look for papilloedema. Now, the next bite was a look at tetracaine local anaesthetic eye drops. And here's Dave's thoughts on this one.
Thanks very much for that podcast on amethocaine or tetracaine. And I looked back on my practice and considered a few things. Firstly, yes, warning the patient that it's going to sting is a very, very good idea. And I do that with children, but I thought about it and thought, well, look, I probably don't do as good a job as I could for adults saying that, this is going to sting. And then I thought, I remember something back in training about using eye drops. And so I looked it up and found some simple instructions. So when instilling an eye drop, always shake the bottle. Only apply one drop at any one time. So if you apply more than one drop, you cause several things. So you cause overflow and you cause a tear reaction, and so you don't get good concentrations. The eye should be closed, and then you should obstruct the nasolacrimal duct. So some statistics: if you put an eye drop in with normal blinking, less than 10% of the drug remains after 5 minutes. If they close their eyes after the drop, 50% of the drug remains after 5 minutes. If you obstruct the nasolacrimal duct, and I've included a picture as a PDF for you to use, 80% of the drug remains after 5 minutes. So use only one drop, repeat after 5 minutes, close the eye and obstruct the duct. So that's how you use the amethocaine. Personally, I have my own little trick for children when I want to get the anaesthetic in, which doesn't completely follow this. I get them to lie down flat, close their eye. I put the drop on the eyelid, and then I get them to blink, and that gets them into their eye. After I've warmed them, it's going to sting. And when I'm putting fluorescein in, I usually put a little bit of amethocaine in it as well. I was not aware of the sulfonamide reaction, so I'm going to think very seriously about that in the future, and say, are you taking any cotrimoxazole, and make sure that we don't do that. The other benefit when you give the drug and you obstruct the nasolacrimal duct is they don't get that horrible taste so much in their mouth because most of it's staying in their eye. The sunblock thing I found was very, very, very interesting. And so I don't know, I guess it's not too much of a bother in winter in New Zealand, but in summer they may have applied a whole lot of sunblock. And it does sound like it's very hard to determine which sunblocks to worry about and which ones not to worry about. So it was a very, very interesting and thoughtful podcast. So there's two other things I considered. The first one, I guess, would be giving the local anaesthetic to the patient for 24 hours. So there's a lot of talk of this in the emergency medicine blogs throughout the world, and they seem very comfortable. But I've also read a lot of ophthalmology blogs saying, look, we are not comfortable with this and we are very concerned, and the studies that have been done are quite poor. I've talked to Auckland ophthalmologists, and I know Auckland ophthalmologists feel very, very, very strongly that you should never give the emeticaine or tetracaine to the patient to take with them. Sure, the eye pain is going to come back, but you should give some oral analgesia at that point. So that's the situation. So definitely local guidelines should apply. And if your ophthalmology centre or your ophthalmologist, if there's only one, is unhappy about you doing it, I suggest you don't give the local anaesthetic to the patient. The other question is eye patching. So when we were growing up as medical students, we were taught to patch the eye if you put local anaesthetics in. And I've breached that question multiple times with ophthalmologists, and they never patch eyes that they haven't operated on. And so I've stopped patching eyes, but obviously you're always very wary of what's the situation in windy environments. So my usual advice is if you've got glasses, wear glasses. If you've got sunglasses, wear sunglasses, but I don't routinely patch the eye, especially in that situation. If I'm worried about a penetrating eye injury, I do the good old-fashioned thing of creating the styrofoam cup eye shield to stop pressure on the eye, and I send them to the eye clinic with the styrofoam cup taped across their eye. And also, you should consider antiemetics in patients that have a globe injury, because you don't want them to vomit forcibly and do more trauma to their eye.
Now, I should say the mention in the bite about eye patching was only relating to that period of time when the eye is still numb. I rarely use them now, and if I do patch an eye, it is usually on that windy day when I'm concerned the patient might get something blown into their eye whilst it is still numb. I certainly don't patch for abrasions, and I follow the Cochrane review from 2016 that found that generally eye patches don't help healing or pain. I particularly like Dave's polystyrene cup eye shield technique, because we do see a fair few occasions of penetrating eye injuries that do need some protection before seeing the ophthalmologist. So that was a nice little tip. Now, Dr. Rob Everson, who's an urgent care fellow from Tauranga, contacted the podcast with his thoughts on both the eye patch use, which he doesn't patch eyes either, and the use of take-home local anaesthetic drops. I'll attach links in the show notes regarding the studies that he quoted for both of his standpoints on these. And the latter suggests that short-term use of local anaesthetic drops in patients creates happier patients, more comfortable patients who heal faster. But like Dave said, it does seem that ED and ophthalmology don't agree on this one. So I personally look at the patient advice sheets which are available online from the website of the Moorfields Eye Hospital from London. They do these really nice take-home sheets that we can print off. And regarding abrasions, they state that local anaesthetic drops are not for home use. And the date on theirs, I think they were either early 2019 or late 2018 that they updated this. So it does seem that ophthalmologists are not keen for it to be used, but some ED guys recommend it for a short period afterwards. So I guess, as is often the case in urgent care, we can become stuck between a pillar and a post. So again, let us know your thoughts on this via email. If you use local anaesthetic drops for a short period afterwards for your patients, have you had any complications? Have you had any pushback from ophthalmologists in your area? But as Dave said, you've got to follow your local policy. So if your local ophthalmologists don't like it, then we're probably duty bound not to go against their advices. Now, we've had some correspondence relating to the urgent bite that we did on Tramadol use back in May. Dr. Mark Baxter, a GP from Merseyside in the UK, wrote to tell us that he has patients who have recently been enrolled in a trial called the PREPARE study. And if I quote from the study's webpage, the goal of PREPARE is to show that preemptively testing patients for an entire panel of clinically relevant pharmacogenomic variant markers will result in an overall reduction in the number of clinically relevant drug genotype-associated adverse drug reactions. Preemptive testing means that the testing is performed before a certain drug is prescribed. So it'll be interesting to see what comes out of this particular study, because predicting patients who might not be able to respond to Tramadol, the people who don't metabolize it at all, or being able to predict that somebody is going to over-metabolize it, will certainly be useful information for us when prescribing. They say they're going to be analysing their data in 2020, so it'll be a little bit of time before we know that, and I wonder if when that actually then becomes clinically relevant in the future, if we can do these tests. But people might be coming to us in the future saying, I've had a genetic test and I don't metabolize Tramadol. So it might change our lives in a little bit. But that was an interesting add-on to that the urgent bite on Tramadol that we had from Justin Morgenstern back in May. So thank you, Mark, for sharing that with us, and also a shout out to Dr. Rhys Lewis, who pointed Mark in the direction of our podcast. Now, in news, the main item this month that drew my attention was a report in the BBC regarding a recent paper in JAMA that has found a link between long-term use of anticholinergics and developing dementia. They said a 50% increased risk when 1,095 total standardised daily doses were given over a 10-year period. I will link the paper and the news articles as it's worth a read, and whilst it's not directly related to urgent care practice, given the long exposure they looked at, we do prescribe anticholinergics, and as such we might get patients asking questions about this study if they've seen it in the headlines. It's quite a striking headline. I think CNN had it as 50% increased risk in dementia. So it's good to be aware of this, even though we might only prescribe short courses of drugs like orphenadrine and promethazine, for example. Patients might just say, "Hey doc, is this one of those drugs that might make us more prone to dementia?" So I thought that was an interesting bit of news to be aware of. In college news, we should let you know that the tickets for the Urgent Care Bootcamp are now available to buy from the college website. It's on September the 14th this year at the Cordis Hotel in Auckland, and as well as tickets to attend the day educational content, you can also get tickets to the college dinner and the fellowship presentation ceremony in the evening, all at the same venue. And you can get that via the website rnzcuc.org.nz. If you're one of the presenters at the Urgent Bootcamp, then your tickets are obviously included in your as a freebie for you doing the presenting. So more information will obviously be coming shortly about timetables and what the presentations are, so check out the website for that. And similarly, if you're an urgent care registrar with the college, make sure you've read the page on the website that's titled Important Information for Registrars in June 2019. I'll put a link in the show notes, but essentially there's information on that page about the training manual now being online. It's got information about the update of the urgent care course. The learning material is being edited and rewritten and brought up to date, so part of that is going live soon, so there's information on that. There's information on the core skills sign-off list, the skills demonstration and assessment weekend, and also important information about getting your notes audit done before the UCPEX exams. So if you're a registrar, make sure you've read that and that you're familiar with all of that. So I apologise for a bitty and shorter podcast this month. That's owing to obviously David being overseas, and I'm shortly leaving myself. So one thing I'm keen to get is a group of people together who can join myself and Dave each month to discuss the urgent bites, the CME interviews, to chat about the news and other college stuff. If you're interested, please let us know. You don't have to be based in Auckland. We can do this over the internet quite easily, and it doesn't have to be a monthly commitment. If we get enough people who are interested, we can have a few rotating people, so we can have a rotating third chair. But I think it's good if we can get some other voices into to discuss these things, to create more of a peer discussion and to bring more viewpoints and more perspectives to things. So if you're interested, then let us know. Send an email to podcast@rnzcuc.org.nz, and it would also mean that when Dave takes a holiday, then we've got other people who can stand in and make this a chat rather than a talk. And talking about getting involved, the CME interview this month is available in a separate podcast. Make sure you've had a listen to that. That, for the first time, involves a college member. Dr. Richard Chen talks about nausea and vomiting in pregnancy. He studied it for his medical literature project as part of his training, and it was an interesting paper that he wrote, so we have got him to talk about that. So it's great that we've got somebody from the college talking on this. And similarly, next week we've got an urgent bite that involves an urgent care registrar. So we're starting to get members of our college involved as well, and we want more people, please. Some of you I know don't want to hear yourself talk, or don't want to be appearing in a podcast form, and that's cool. It's not for everybody, but certainly if you've got any other way that you want to contribute, you can present a case in written form, and we can talk about it. But it's certainly great if we can get you guys involved as much as we can. As I mentioned just earlier, I'm off overseas now, but we will continue uploading some podcasts, and I might even be hopefully bringing something from my travels to the podcast as well. So we'll be back next week with the Urgent Bite, and as ever, I look forward to seeing you all then. But for now, thanks for listening. The information discussed in this podcast was intended for the ongoing professional development of qualified health professionals and should not be used for self-diagnosis. For any personal medical concerns, please consult your usual doctor.